Okay, welcome to the COVID-19 Frontline with CGTN Think Tank. As the coronavirus continues to spread around the world, no one should underestimate the power of this invisible enemy. It is now a battle not only facing one person, one city, or one country. It is a global battle facing all mankind. We need to ratchet up our efforts, integrate our resources, and share expertise around the world. So to provide some insights on the fight against the coronavirus, we are honored to have 7 experts and scholars from across the globe joining us today to have a discussion. An online meeting is limited to 100 viewers, but you can watch the live broadcast on the CGTN website and our accounts on Weibo, Facebook, YouTube, and Twitter. If you have any questions for our guest speakers, please leave a message in the comment sections of our social media accounts. And to start, our guest speakers will have 5 minutes to make a statement about the COVID-19 and our human response. And then there will be open discussions. And finally, we have a Q&A session where our viewers online can ask their questions and our experts will try their best to give their answers. So why don't we just get started without further ado? Let's start with Elisabetta, a virologist and lecturer in the global health at the Institute for Infection and Immunity at St. George's University of London. Elisabetta?
Hello, it's a fantastic pleasure to be able to meet you and also to contribute to this think tank. I have some slides, so I'm going to share the screen so we can all look at the slides. So my specialty especially is on testing. And I think when it comes to the COVID-19 and the virus, it's just important to remember that this virus is made of, it's got an RNA genome. And the samples that have been, apologies, there's something wrong with the slides. And okay, I'll go without slides then. The RNA genome is found on the inside of the virus, and the molecular test detects the viral RNA, which is in a sample, normally in a swab. And the test is very specific, but also very accurate, and it can be quickly adapted in case there are genetic variation on the virus, including potential for different strains. However, the test is very time-consuming because it takes at least 8 hours, so the turnaround times from taking the samples to the patients actually can be much more longer than that. Sometimes in some countries they can go in terms of days. It is also very research heavy because of the reagents, the molecular reagents that are required, and also the facilities and the equipment. But also we need to remember that in order to perform this test, we need to have very highly skilled and trained laboratory scientists. It's also important to understand when this test can be applied, and because the characteristics of the test is that it can only detect an ongoing infection. So when there is a lot of the genome circulating in a sample, and generally speaking, we can say that it detects active cases. So it's important to point out that it cannot therefore detect if a person was positive in the past and therefore cannot inform on the immunological memory and the potential immunity of patients that have recovered from the infection. I have to admit that tests that address this specific point are in development, and actually the UK government has announced last night that a procurement for a large number of these tests have been started. So the other important point about the test is actually who gets to be tested. And at the moment, the recommendations are to test only those patients that have symptoms, including, generally speaking, a cough, consistent, persistent cough, and or a temperature. However, we've seen in many countries that actually the bottleneck for the testing is the resources. As I said, this test is quite complex and heavy on the resources. So countries have had to prioritize. And the UK at the moment has decided that it will only test patients that require hospitalization. So this is very different compared to what Italy had started doing when they detected the first cases. However, Italy had subsequently had to move to limiting the test only to severe cases. And of course, we are all aware of actually aggressive strategy for testing that is happening in South Korea and, of course, China as well. So what I would like to say is that testing by itself is, of course, crucial in fighting the virus. And we can see the different aspects of the I'm so sorry, there's something wrong with the presentation. Testing is crucial in fighting the virus because of what the testing helps with, which is epidemiologically, which means understanding who is positive and therefore informing the response. Is also crucial for the healthcare workers because of the protective equipment that they need to use if the patient is positive, but also if for the patient themselves, because we've learned from, thanks to data that has been shared from China and Italy, especially, that if a patient is positive then and also has comorbidities, so pre-existing medical conditions, the clinical picture and the care that is required is going to be much more complex, and this is important in informing the response. And of course, testing is also crucial to understand what's going on, the amount of virus that is circulating in a population. And I'm just sharing here a graph. This is not my data, it's from Esteban Ortiz Ospina, that has showed that actually how different countries actually have conducted tests, and makes a point that actually the more tests you do in a population, the better the idea of you have about the amount of virus that is circulating, and therefore you can have a better informed response, which is can be absolutely summarized by the words of Dr. Tedros, the WHO Director General, which summarize everything with test, test, test. Thank you.
A quick question, Elisabetta. The gap of test rates in different countries, is it more a logistical problem, or there are different benchmarks for who will go through testing?
The different countries have adopted different strategies, and mainly it's actually due to the resources. There is the general idea for all the scientists that as much testing that can be done should be done, both for the patients and for the response. The reality is that the test is time-consuming. Kits for extracting the RNA and providing the test are a limiting factor, a bottleneck, and therefore individual countries have different supply chains and different kits, and can therefore tailor the number of tests that they can do to the response that they can provide.
All right, our next speaker, Mr. Jeffrey Shaman from the US.
Thank you for having me. I'm happy to contribute here. I'm an infectious disease epidemiologist. I'm really a modeler. I look at the dynamics of the transmission of viruses in populations and their movement and spread. And there is a lot to be learned about what's going on with this virus. I'm going to show slides for the time being. But the main factors that make this virus so critically difficult are that it has a couple of ingredients that allow it to really have strong pandemic potential. The first is that there are a lot of undocumented cases or infections within the population generally in the absence of extremely aggressive, proactive sampling of the community. A lot of the people who are infected with this virus have mild symptoms and typically do what most of us do when we're infected with a common cold, which is that we have mild symptoms. We might take some ibuprofen, we might take some cold medicine, but we're typically going to go about our day. We'll go to work, we'll go shopping, we have a business trip, we'll go on it. We might even go on vacation if we have that planned. And because of that, we facilitate the movement and the transmission and the spread within communities of these common respiratory viruses. This virus has that property. We have estimates for China prior to the travel restrictions and control measures that were adopted on January 23rd, that only 1 in 7 of the infections circulating in the community were actually confirmed at that time. When we look at other countries, we see something similar unless they really adopt proactive sampling measures, such as what happened in China after the travel restrictions, or as what happened in South Korea once they realized they had this real large problem on their hand. The other complication, of course, is that this virus not only produces a lot of mild undocumented infections that can spread because they're contagious, but it also has the property that it has a fat tail, where there's a portion of the population for which the outcomes are quite severe. Hence, we're having a lot of people coming to hospitals, winding up in the ICU, and it has a high case fatality rate. Estimates range from 10 to 30 times what we see for seasonal flu. And given the full susceptibility of the world's population to it, it's going to spread very quickly because of this sort of silent transmission by these people who really don't recognize that they're infected, and it's going to have really large impacts on the community at large. I would like to reiterate what the previous speaker said, that testing is really one of the keys to finding where it is in the community, and it has to be done in a proactive way. The strategies of identifying patients, isolating those who are positive, quarantining their friends and neighbors and contacts, and then monitoring them and testing those individuals as well, are proving to be successful in the countries that are adopting them. We unfortunately have a bit of a natural experiment because we're seeing different policies implemented in different countries. Some are pursuing very aggressive means and measures to try to control the virus. Others, frankly, appear to be in a bit of denial as to what's going on, and they're not even encouraging testing, and we don't really know the extent of the virus's movement within those populations. We're going to see in hindsight, unfortunately, when the dust settles, what were the effective approaches in dealing with this virus and how well it paid off to be aggressive and how aggressive one needs to be. Because obviously, when you impose these kinds of control measures, there are economic costs, there are psychological and emotional costs, and there are other risks associated with the disruption that happens with isolation, quarantine, social distancing, and the closing of businesses and normal activity. I'll stop there.
One quick question, Jeffrey, about the human consequences. There is a huge gap of fatality. For example, in Italy, it's almost 8%. In China, it's around 1.7%. In South Korea, it's less than 1%.
Yes.
Why there is such huge gap of fatality in different countries? Is it because of the control policies differences?
I think that plays a large role in it. Now, we can't discount the fact that there may be different variants of the strain of the virus in these countries, and there's been some identification and work that's classified multiple variants that have spread out, and I don't know the extent to which that may be effect. But it does line up with the fact that China was so aggressive in its testing after January 23rd. When we look at the data there, we estimate that 2/3 of infections were identified after control measures were implemented and China began aggressive testing. I think South Korea has done so as well. And you have to remember that this case fatality rate is simply deaths divided by confirmed cases. And if you're out in the community and actively looking for the virus, you will confirm more cases. You're going to inflate that denominator, and it's going to approach what's really called the infection fatality rate, which is the number of actual infections, regardless of their symptomology in the community. And that is the denominator now, so it's the number of deaths divided by that. So aggressive testing will lower the appearance of the case fatality rate in those countries. But it doesn't mean the virus isn't just as dangerous potentially.
Of course. Our next speaker, Johan Nates. Johan?
Yes, hello. Thanks a lot for having me. So my lab at the University of Leuven in Belgium has a focus on both the development of vaccines and the development of therapeutics, antivirals, and we do not do that only against coronaviruses, but also against several other virus families. So we're quite moving well on developing a vaccine, prototype vaccine candidate against the virus. But the point I would like to make is that with vaccines, that you can only start basically making the vaccine at the time that you know the new pathogen, which was basically, so the genetic sequence of the virus was put online by teams in China on 12th of January. So at that time, which is now about 2 months ago, so teams around the world could basically start working on the vaccine. And as the director of the WHO said, I mean, it will likely be until the summer of 2021 before we have a vaccine or before we have vaccines. So the point is that in this interface, this interludium phase in which we are now, that you basically don't have any weapon besides putting people into isolation and quarantine to contain this outbreak. So what you would need basically at this stage are drugs, highly potent antiviral drugs, therapeutics that you can use to treat those that are most sick, and also to prevent infection in doctors and nurses, and to prevent infection in contacts. So we don't have these, and we know that you can develop highly potent drugs. Just think about HIV. I mean, we have 30 drugs around to treat HIV. With just 1 pill a day, you can keep HIV under control. Hepatitis C, that gives a liver infection. With just 1 or 2 pills a day, you can basically cure people. 99% of the people, you can cure them with highly potent antiviral drugs in just 2 months' time. So I'm absolutely convinced, and it will be the case, that it should be possible to have a highly potent antiviral against this virus and against coronaviruses as a whole. But it takes 10 years before you have developed a highly potent drug. So we don't have that time. So what we now need to do, and this is also what we're doing, and we'll show you just a couple of slides in a minute, what we're doing is we try to find an existing medications, existing drugs, if there's perhaps nothing that may block the replication of the virus a little bit, and that you could then use in patients to basically block the replication on the lungs a little bit, and perhaps make a difference for these most sick patients between life and death. And as many of you know, the anti-Ebola compound remdesivir from Gilead Sciences is currently being tested. Hopefully, it may the data may be positive, and we may be using then the compound to treat the most sick. Also, the anti-malaria compound chloroquine has some activity on some other compounds. And by the way, back in 2004, my colleague Mark van Ranst and myself, we published on the activity of chloroquine against the SARS coronavirus. So I'm happy to see that the compound apparently does have some beneficial effect in patients. But the point is that we are way too late. And so imagine that we had taken lessons from the 2003 coronavirus outbreak, the SARS outbreak, and then the MERS coronavirus outbreak in 2012. So SARS now 16, 17 years ago, we would have had the time to come up with highly potent drugs against coronaviruses. So we knew until a couple of months ago 6 coronaviruses that give just mild symptoms, kind of common cold, and 2 the SARS and the MERS that give bad symptoms. So based on the 6 viruses, mankind could have prepared and basically had something on the shelf, a highly potent, or perhaps 2 highly potent pan-corona compounds that should also be active against a new coronavirus if it would emerge, which basically happened in December and January in Wuhan. So just imagine that we had back in December and January, that WHO could have a stockpile of a highly potent drug against coronavirus that they could fly into Wuhan. Something that is done, for example, with the vaccine of yellow fever, there's a stockpile at the WHO. So just imagine that we could have shipped a couple of thousand doses to Wuhan to treat the most sick patients, to help them to survive, but also to basically treat doctors and nurses and help them protect them, and also treat basically the contacts of infected people. That would have helped a lot, together with quarantine measures, to basically stop this little this initial phase of the epidemic, and basically prevent that this would become now this big pandemic problem that we're facing today. So what I'm saying is this should be the last time that we are seeing such big pandemic. We should be prepared for the next one. We should basically make sure that we have, for each of the families of viruses that we know that can yield bad pathogens, we should have on the shelf a stockpile of highly potent antiviral drugs that can be used to stop, together with quarantine measures, in the very beginning of an epidemic, and before we have a vaccine, because you can only start making vaccines, as I said, at the time that you know the pathogen. So we should basically make sure that we have those measures.
Okay, a reminder, there are 100 viewers within the platform. They have kept raising their hands. Please be patient. We will have Q&A later in this segment. One quick question, Johan. You mentioned chloroquine and also remdesivir. The Chinese doctors have put them into clinical trials, and the American administration seems want to tout the potency of these two drugs. Is there any other candidates, antiviral drugs?
Well, there is no specific antiviral against coronaviruses. So anything that's being used is sort of something that has been developed against another indication. There are HIV protease inhibitors that showed some activity in cell culture against coronaviruses, but it was just published in the New England Journal of Medicine a couple of days ago that this doesn't give an additional or does not have a positive impact in patients. There's just a study published and not published, but a message was put online by a team in Marseille in France that the anti-malaria compound chloroquine, together with an antibiotic, has some additional beneficial effect if you combine both of them. And a couple of other drugs are being tested for the moment. But as you understand, these are all so that they will perhaps a little bit, but what we would need in the future is drugs that are really potent, as those drugs that we have to treat HIV and hepatitis C, for example.
All right, thank you, Johan. Our next speaker is Professor Li Guangxi, the director of the Pulmonary Division of Guang'an Main Hospital at China Academy of Chinese Medical Science. Professor Li?
Oh, yes, hello everyone. So I would like to talk from the Chinese medicine standpoint. So I would like to share some slides here. So I think the most important thing here is preventing acute lung injury using Chinese medicine. You know, the COVID-19, the dangerous part is acute lung injury, and finally they develop ARDS and they died from that. So today my topic will only cover how we use the Chinese medicine successfully prevent the progression of acute lung injury. Just like the previous speaker said, we don't have a good drug right now against the COVID-19. Like some study already show that the current clinical presentation of the patients is on the fever, cough, shortness of breath, mild to severe, something. But I think the major thing they don't mention is the stage, different dates of the symptoms. So the first, I think the mild cases initially they will happen, but later on they will progress to the severe cases, not on the first several days. So that's what we saw. So we from the data we have seen is we probably the incubation period, I don't know the exact date, but maybe from 2 to 14 days, usually no symptoms and no transmission. And then the second part is a fever period. It's usually it's the first week of the disease. So this is the golden window to prevent the development of acute lung injury. And you will, if you prevent acute lung injury very successfully, and then you will have very few patients falling into the ARDS and acute lung injury. So that's the thing, we need to focus on this part, those first week treatment, especially the fever and the cough. So, and then maybe in London, I saw some patients from London, actually they don't have so much cough. Initially they only have diarrhea. So that's maybe different in London. So in the second week of disease, the acute lung injury will develop. So this is the second week. So they probably coming from the delayed treatment, or they have some kind of baseline disease, and the prolonged fever could trigger the acute lung injury. So, and then finally the recovery period, that will be after 2 weeks. So usually if you can overcome the difficulty of the acute lung injury, you probably will not have too much symptoms. You only have maybe something left in your chest CT, but not so severe. Then your life will come back to the baseline after maybe 1 month or 2 months of rehabilitation. That's what we saw. So right now, what we are doing is doing quite a lot of research to rehabilitate patients. So regarding the incubation window, that's usually no symptom and no transmission, but I'm not sure if they usually they do have or may not have transmission during this incubation window. But maybe the other experts could answer me these questions later. So regarding the fever window, I think this is a very controversial part. So right now, some experts said, we don't have a good antiviral drug. We don't have the steroids should not be used. But I think what we tried is the best effect method is the Chinese medicine. So we use the different Chinese herb to give the patients, and they do get quite a lot of recovery. So the only medication we recommend is Chinese medicine. So that's what we use for the part. So you ginseng, I think everybody knows, but some other drugs maybe you don't know. But regarding the ginger and some kind of mint tea, herbal mint tea, you may also have that in your grocery store. So these drugs could help patients to have sweat, and then later on their fever will go down, and then they will not have any the later on problem. So regarding the most important part we thought is early prevention. So my suggestion for the patients is should monitor their fever closely and then monitor their oxygen saturation with pulse oximeter closely. And also you need to monitor your cough and shortness of breath and some other symptoms. So that's what we saw in our early stage. So that's what we treated. So now this is one family case. So this man is about 76 with fever 2 days, and I treated remotely. You can see, so with a lot of comorbidities, hypertension, diabetes, the vascular disease, and we treated with Chinese medicine about only two days, and then the fever gone, and he don't need any support. He just go to the hospital for quarantine. Nothing else they did on him. So this is the case. And 4 days later, you can see, his chest CT obviously has some kind of the absorption and not so severe like before. So this is 4 days after the first CT. So next slide. And this is his son. His son CT is like this. So we can still see some kind of mild infiltrate in the left upper lung. So this patient also has some fever, but after his whole family take the same medication, same Chinese herb, and they all get recovered. That's the very strong proof for we can treat these patients, with Chinese medicine. So there's some kind of fever late stage. That means they already had quite a severe lung injury. So this patient has about 52 years old, marathon runner. So his baseline condition is very good, and they use some kind of Western medicine drug like moxifloxacin, plus steroids, and fever increased from 38 to 39.8 Celsius. So they had cough, shortness of breath. And later on, we measure the chest CT. You can see quite a lot of infiltrate, in the lower lungs, both sides. So clearly, he started to develop acute lung injury, and we gave the Chinese herb. After only 1 day, the fever gone, and everything is gone. So he don't need any steroids. He don't need any antibiotics. So and he recovered. And right now, he don't have any symptoms. So there's another case. So here is another case. So we can see this patient is a little bit different. He already had the fever about 2 weeks. So he had quite a severe coughing and shortness of breath. So, and then his lung is, his saturation go down to 87% on the oxygen level on the 5-liter oxygen support. So but he is a very, very severe cases, and they almost put him on the intubation, and finally we use Chinese herbs to save his life without intubation. And now you can see after 1 month, he recovered very good.
Okay.
So that's So maybe I talk too much.
Thank you very much, Professor Li, for your introduction about the Chinese medicine's treatment. let's go to our next speaker, Margaret Harris from WHO. Margaret?
Good. Thank you. Thank you very much. Good evening, and thank you for having me in this really eminent group. I'm a public health doctor, and I'm a specialist in emergency risk communications. And I'm really heartened to hear all the good messages and good information that all the panelists are saying, especially test, test, test. And we certainly are seeing here in Europe where the epicenter has clearly shifted to, and where we've seen the huge outbreaks have led to cases doubling to more than 200,000 within 12 days. It took 12 weeks to get to 100,000, 12 days to get to 200,000. And there is great concern that indeed not enough people are being tested. And our main message that we are still, struggling to get through is that the old tried and true methods, the testing, the finding all cases, finding all people who are exposed to those confirmed cases and isolating everybody, as was done very successfully in Wuhan, is what needs to be done. We thank very much we are very thankful for the great work that's been done in China and other Asian countries, because it's demonstrating that it is possible to stop this outbreak. It is possible to end this outbreak if that hard work is done. My final message, really, because I want to actually hear what the other panelists are saying, because this is a rich and exciting event, is that one of the problems was, because we have this spectrum of disease with this virus, we have many people with very mild symptoms, and we have the other end where people are very, very sick and are severely ill. For a long time, people really just thought, well, it won't affect me. It's not a problem for me. So getting that message through was very difficult, even though people were warning from early on. We called it a public health emergency of international concern on January 30, but we're still having people saying, why weren't you telling us it was a problem? So getting that message through has been very difficult. And I really appreciate all the efforts of everybody here to get testing, treatments going, because now, unfortunately, that message has come home to everyone, but now they are looking for the scientific community to come together as they have and to find solutions. So thank you very much to all of you.
Well, thank you, Margaret. We should wake up to this. Next speaker is Mr. Yoichi Matsuzoe. He is a former Japanese Minister of Health, Labor and Welfare and former governor of Tokyo. Mr. Matsuzoe.
Thank you for having me. As a political leader who really handled the H1N1 in 2009, just I'd like to mention several points in terms of political crisis management. The first point is the importance of disclosure of all information. Fortunately enough, we have a bunch of data from China, from Italy, and WHO analyzed all, and we are making maximum use of, all these kind of information. So political leaders should, based on these valuable information, to speak directly to the people. And in that context, I'd like to say, in case of crisis like that, the political leaders should directly speak to the nation, to the people, and as frequently as possible. The people are so scared that top leaders should explain and appease them. This is politically very, very important. Another thing is, for example, if I have to decide to close all schools or not, just take examples of UK and Germany. They really hesitated to that. And in Japanese case, the same thing. But final decision should be done by a political leader. So that it's really very, very hard to lock down the city, to close all enterprises. So that if possible, we'd like to have at least 2 or 3 team of experts who can give me this kind of information, this kind of proposal, then I can gather several different propositions and I can decide. So the experts are very, very important in order that political leaders can implement really correct decisions. And finally, my point is that we have the flexibility to change the response, to change the policies in the face of crisis of coronaviruses. In Japan, fortunately enough, the number of deaths is so small compared with other countries, in European countries, and also the number of patients. So we are slightly moving our measures not to bring the people, the patient with mild symptoms to go to hospitals. We will ask them to stay at home and don't go to the hospital. That like that we cannot have in-hospital infections. And it is very, very important for political leaders, according to the phase of the diseases, the infection, you can change, you have to change very, very, with much flexibility, your response. If not, just compare Italy and Japan and other countries. One of the tragedy of Italy is to accept all kind of patients, mild symptom or severe symptom, and finally, the lack of hospitals and medical treatment and medicine. So that's my point is the importance of flexibility. Okay, thank you.
Okay, thank you, Mr. Pesuzoa. Our final speaker is Mr. Joning from the cardiology section of Chongji Hospital and also Associate Professor of Chongji Medical College of Huazhong University of Science and Technology. Dr. Zhou?
Hello, this is Nin Zhou from Wuhan. Yeah, thank you for having me here. I'm a cardiologist, but I've worked in the ICU ward for the COVID-19 patient for over 14 days since Feb 10. So I have some experience and also some lessons to share with you guys. As you know that Wuhan is not so famous before, but now it's very well known because it's the epicenter. It was the epicenter of the COVID-19 epidemic. But you know that there's a good news I want to share with you. From yesterday, the new cases in Wuhan city is 0. So we have no more new cases anymore. That's very good news. That means we have a very good control of the outbreak of COVID-19. But you know, in Wuhan, we still have more than 2,000 people died from the COVID-19. That means this virus is also very lethal, right? So, to my opinion, there's around 20% of the infected person might develop into a very severe or very critical severe type. You know, especially for those very old people. So sometimes this virus is very deadly for them. And I work in the ICU ward. We have 30 beds, and in the February 10th and February 20, the beds is full. We have a lot of patients there, and people died. A lot of patients died. So the mortality rate of the severe and the critical severe patient is over 60%. So that's too bad. That means 60% of the severe or critically severe patient will die from the COVID-19. But right now we have a much lower mortality rate because we have some very good experience to treat this kind of the viral pneumonia. So, but actually, we don't have enough evidence to show that the antivirus drugs we used is very specific or effective for the COVID-19. But what we use is the expectant therapy for them. For example, you know, most of the patient with a severe or critically severe type is short of breath. That means he's in a great shortage of the oxygen. So the shortage of oxygen will damage the other organs. So and you can understand why I'm a cardiologist, why I came to the ICU ward for the COVID-19 patient. So I would say that this virus is very bad. It's the lungs, you know, that this virus affects the lungs, right? Impairs the lungs function, but actually it can attack all of the other organs, especially for the lung, especially for the heart, the kidney, and the liver. So most of the patient, I mean, especially for those very old guys, you die from the hypoxemia, but not only the hypoxemia, but also die from the heart failure, liver failure, kidney failure. This is caused by a inflammatory storm. So that's the mechanism. So we use the expectant therapy for this patient, especially for the ventilation to supply enough oxygen for this patient. This is the first step for this very, very severe patient. Also, if the ventilation is not enough to support enough oxygen for the patient, we use ECMO. Actually, we have finished 6 ECMO in my ward, and all of the patients survived. That's very, very good. Very good method to save lives. And but to be honest, we don't have enough ECMO systems so far. Well, I'm not sure whether it's correct. There is only 1,200 ECMO systems in this world, but
probably
400.
Yeah, go ahead. We just lost you. You are connected again.
Okay, the 400 ECMO system is in China, and in my hospital we have 16 ECMO system, and is still in running for another two patients. So, to my opinion, ECMO is very effective for the patient with a very severe or critical severe COVID-19, and also to treating the inflammatory storm, CRRT, that means a blood purification. That's also very important and effective, to my opinion. It can reduce cytokines in the blood of the patient, and reduce the inflammatory storm, and stop the attack of the storm to the other organs, including the heart. So, and I also observed that some of the patients die from the fulminant myocarditis as a very severe heart failure, and also a sudden cardiac death. So this is the support system for the critically severe COVID-19 patient. And also there is a very controversial issue, as whether or how we use a steroid for the patient with a severe or critically severe COVID-19. In my ward, most of patients receive the therapy of steroid. For those patients with a very, very severe lung lesion caused by the virus, and the oxygenation index is very low. So the OI index, the oxygenation index is lower than 100 millicurie. That's a very important indicator for the therapy of ECMO. And also in this kind of patient, a steroid is very, very helpful. So we use the steroid very generally. And also for the another very controversial issue is the antibacterial. So I don't think that the antibacterial is very useful for the treatment of the severe or critically severe patient, because this is a virus disease. This is not caused by the infection of bacteria, but in the very late stage of this very severe patient, some of them may have a secondary bacterial infection, but that's another issue. But in the early stage, I don't think that the antibacterial is helpful for the treatment of this patient. So far we have 15 patients in my ward. We have discharged some of them, and I think the mortality rate is getting lower and lower. So far, generally in China, the mortality rate of the COVID-19 is around 4%, but in my ward, maybe much lower. But I don't have the very accurate account, but it's lower. Oh, thank you.
And Mr. Lee, I want you to answer this. Have you communicated your experiences in combating this disease enough to the international community of your profession? I mean, doctors from other countries.
With other countries?
Let's Dr. Lee answer this question, please.
Okay.
Oh, you mean me? Okay.
Yeah.
So I talk with some patients. I did talk with my male colleagues. They are trying to start some trials with some part of Chinese medicine because we don't have the whole bunch of that allowed in FDA. So they may try start from the aspirin plus ginseng, something like that. So we basically use some kinds of insects plus some Chinese herb, which one can be used in the United States. That's what we talk. But in some other countries, like in London, I'm still talking with some doctors, and like Italy, we also talk, and Iran, we also talk. So I did talk with many countries, physicians, and we try to stop the disease early. So just prevent the fall of the cliff. So everything needs to be done as early as possible. So triage patients according to their different conditions. That's very important. So you need to find a predictor who will be the very severe patient. Right now, we don't know yet. So we need to know what's the major predictor. So we are trying to collect our data, and we will submit one paper, very important paper, this weekend to the Lancet.
About the global picture, Elisabetta, I wanted you to update us on the European situation. How bad is it in Europe, and what are the most pressing issues? It seems that the British have got a lot of criticism for its ideas of herd immunity.
Right, so I appreciated we're talking about Europe, and I myself look closely at the situation in the UK because that's where I live and work, but also Italy because that's where I come from and where family and friends are. And I can say that it is a very varied situation. There are very different situations, different scenarios. And by concentrating on Italy and the UK, one question that I get asked all the time in the UK, considering the gravity and how critical the situation in Italy, does it mean that the UK is just a couple of weeks behind or 3 weeks behind? And the UK is behind in the sense that the UK has a very different situation because it's had time to look at what's happening around the world and has had time to look for an alternative assessment, an alternative response. Or actually, it's not something completely new. It's simply looking at a bit of it creatively about what the data is and what we can learn from that. And that also is not just about the virus, but is also the response that the population has. Because what Italy has shown that even though the situation started much critically, it also went worse very quickly. And the virus, of course, as we heard, there might be some differences in the genetic sequence. However, it doesn't seem to be at the moment that we have completely different viruses that could explain the speed. What is different actually is the response of and the responsibility that each member of the public has taken upon itself. And so the UK has been able to witness this and decided to go for a more incremental approach when it comes to communicating, engaging with the public. And so smaller bits of information so to make sure that the message is taken on board. Unfortunately, this has taken some criticism because now we are seeing the opposite problem that people are a little bit of incredulous that the virus is here. And also this combined with the fact that testing is still quite prioritized for at the moment. It will change. It seems, I think, to give a sense of security in the UK, in the general public, which unfortunately is certainly not what the government is saying. But I think it does explain the different in approaches, the different in communications. But the British authorities are absolutely using science to inform their response.
Okay, I have a quick question for Margaret. Margaret, a lot of people here in China are wondering whether it is appropriate to wear masks for the average citizens, because it's almost everybody here in China wear masks. According to the WHO and the CDC, it seems that only those who are taking care of the sick and those medical staff should wear masks. So what is the correct way of understanding wear masks? Margaret?
Okay, this it's got to be understood. Wearing a mask is a cultural norm in China, in Hong Kong, in much of Asia, not just for infection, but for concern about air pollution and other things. So it's used in a different way. But if you are trying to prevent yourself from catching a virus, wearing a mask is not going to do it. Wearing a mask is something you do if you're actively coughing or sneezing. And that is what a lot of people why people in Asia do wear it, because it's an etiquette thing. It's like, I'm going to protect you from what I might be carrying. Now at the moment, we have a worldwide shortage of masks. Masks are really needed to protect healthcare workers. So that's why, especially in Europe, where it is not a cultural norm, we say to people, please do not wear a mask, because it is not something that is going to protect you in the general public, but it is something that will protect a healthcare worker who's facing somebody who's actively infectious.
But it would do no harm to somebody who wear masks, or it give them a false sense of safety.
There is a concern also, it can give them a false sense of safety. They may not focus on the thing that really protects you, which is washing your hands and not touching your nose, your mouth, your eyes. And people sometimes pull it down on their nose and play with the front of it. And again, if you've got all kinds of respiratory secretions all over your mask, and you then put your hands on the tables and around, if you have got anything, you're really spreading it that way. Also, some people tend to be a little bit lazy and just throw their mask on the ground or don't dispose of it properly. So again, that can spread infection. So that's another reason we ask that people use a mask appropriately. We don't say that there's anything wrong with you for using a mask, but think about why you might use a mask and who needs to use it most, and make those choices wisely.
Okay, let me pick some questions from our audience in this chat room. And Zeiss, wow, this is a question, big one. How many people will die? Any solutions the world would work together to stop this? Probably, Margaret, your take on this? How many people die?
It's how long is a piece of string, because we don't know how many cases. We want to stop this, but we are seeing case fatality rates as high as 8.5%, 9% in some very bad outbreaks. In China, you had a lower case fatality rate in the end, but as was mentioned, you were testing more people, so it was clearer. So what I'd like to say is no more, but we are at a stage where more people are going to die. We won't be able to give you a number at the end, and until that happy day when this is all over.
And Jeffrey, I want your take on this question. Andy Zeiss, he also asked, what strategies have proved most effective in the fight so far? It seems different countries have different approaches in tackling the outbreak of this coronavirus. Can you assess on the different countries' approaches and their effectiveness?
You know, it's a little difficult to tell, because the information you need to really assess it is hard to say. I think from the perspective of protecting healthcare systems, it appears that Asian countries are doing the best. When we look at what's happened in Singapore, in Hong Kong, in Japan, they have really linear growth in the number of cases. And it may reflect the measures that they have taken and how aggressively they've actually tried to nip it in the bud before things go haywire. I think the responses that we see in China and South Korea are really to be noted, because in those instances, they experienced rapid exponential growth and the situation really seemed to get out of hand. But the government and the population's response in terms of isolation, quarantine, shelter in place, and active testing really brought the outbreak under control. So I think those are right now are the examples that we need to really look at. longer term, because we don't have a vaccine, because we don't have effective therapeutic treatments right now, we have a larger problem, which is that if you relax those measures that are in place, which may be something that starts to happen because we may have to do this for months, if not for a year at this rate, you may see a rebound. And then the question is, does a society have the stamina to impose these measures for a very prolonged period of time?
I want to follow up on that, because China has seen no new infections, homegrown new infections, but a lot of people are still edgy whether the resumption of normal economic activities will lead to a resurgence of cases here in China. What does it take to prevent that from happening?
I think a return to normal activity almost begs a resurgence of the virus right now, unfortunately. If normal activity includes international trade and travel and commuting, you're going to have a reintroduction of the virus. Much of the population of China is still susceptible to it, and it will spread very proficiently, very efficiently within China in those areas where people have not been exposed previously. We have an ongoing problem because of this, which is why this questioner asks, what's the worst case scenario, and how many cases and how many fatalities might we see? In a pandemic situation, particularly with a respiratory virus that spreads efficiently, you're looking at something that, if it is not constrained through active measures, is going to affect 50 to 70% of the world's population within a few years. Given the timescales we're talking about for vaccine development and the development of targeted, effective antivirals with therapeutics, we're really looking at something where we're going to be in a new normal, for a prolonged period of time, where people are going to have to adjust their lifestyles and economies are going to be disrupted.
How extended period of time will that be? Are we talking about months or years?
I'm afraid to say I think we're talking up to a year to a year and a half. If the target is a vaccine coming out in the summer of 2021, obviously we would like to walk that timeline back and have a vaccine that's effective and safe and distributed en masse to be out there much earlier. But that is probably the point in time when we're going to effectively be able to come out in the sun again and return to normalcy in a way that we would really hope.
Okay, talking about vaccines, Johan, it seems the conventional wisdom, it would take a year and a half to have a vaccine available for the entire human beings. Can we speed it up, and how? Johan?
I think 18 months is even not conventional. I mean, 18 months would be incredibly fast. I think that never happened, that you have a vaccine from scratch in 18 months and distributed around the world to hundreds of millions and have billions of people. I think 18 months is quite optimistic, but okay, I mean, what I'm seeing now is that in many countries, a lot is happening to even speed up this thing as much as possible, and perhaps we can even cut it down to with a couple of more months, but I'm not sure that this will be possible. So I think we really have to sort of indeed see this spreading without having a vaccine in the next year to contain it.
And I also heard there were competitions between Chinese, European, and American pharmaceutical companies to come up with the vaccine first. Is this competition benign, or is it helpful for the coming up of a vaccine?
What I see,
is there possibility of cooperation?
Yeah, I think so. So what I see is not really competition between the companies, but that each company or team is trying to move as fast as possible. And I think it's good that we are with quite a bit of teams and companies in this race, because some will not make it, some will not be good enough. For some of them, perhaps you need 2 or 3 injections. And I think what you would like to have is just a vaccine where you need just 1 injection to have protection. So with the more companies, the more teams we are in this race, hopefully the more of them will be able to come up in the end with a vaccine. And I think it's also good that we have multiple technologies to develop a vaccine, because you don't want to lay all your eggs in just one basket. You need also production capacity. You need to scale up to billions of doses, and you can't do that with just one technology. So I think it's good, and I think it's kind of a healthy competition. It's not a competition against each other. It's really all against this damn virus. I mean, all running as fast as possible to come up with the vaccine.
Okay, next question is Haiga Zep LaRouche. He said that given the fact that the coronavirus pandemic was spread to Southern Hemisphere, where the country's extremely poor health systems, it threatens to be devastating there, and it will come back in waves to the Northern Hemisphere. I think this is a very important question, Margaret. What about those countries living in Southern Hemisphere, in Sub-Saharan Africa, Latin America, which probably have weaker public health systems? How are they going to cope with the outbreak, if there is any?
So, in fact, the most southern hemisphere country it's in is Australia, and they have a very strong health system. I should correct you there.
Okay.
But indeed, Sub-Saharan Africa, which is really equatorial, and some of them are actually north, indeed is a concern. One of the positives in Africa is that they know outbreaks. They have outbreaks all the time. In fact, for them, it's the norm. So people in Africa understand the risks. And when they are asked to do things like accept closure of schools, accept distancing measures, they are quite used to doing this. I've just returned from Congo fighting Ebola in a war zone. And we're really hoping we're going to have very good news on the 12th of April to be able to say that has finished. And I could tell you in November, when we were having our teams attacked and murdered, I thought that would never end. So even though indeed this virus has the ability to overwhelm populations and weak health systems, and we've certainly seen that with Ebola, the positive is that these are countries that understand outbreaks. And we've certainly seen the countries that understood a coronavirus outbreak, like Korea, like China, and Singapore, have responded effectively. So just having that knowledge is a positive.
All right. Next question. Probably this question should reserve for Dr. Lee and Dr. Zhou. It says, would it be urgent that maybe China calls for a world emergency summit to establish a health system for every country on the planet? Mr. Lee, what do you think of China championing a summit and dealing with this, as obviously it started from here?
Yeah, I think it's we probably need to share our experience with some other countries and other professional workers, so we could let them know how we deal with the patient. But I still, because it's quite a lot of political issues, so I think maybe they could answer better. So, but I think it's urgent for us to do that.
And Mr. Zhou, in terms of your medical profession and also public health perspective, what is the China's best experience in dealing with this disease? Mr. Zhou, are you still there? Well, seems we've lost Dr. Zhou there in Tongji Hospital, the epicenter.
Yeah,
Mr. Lee, your take, what do you think China has gained from treating this disease for 2 months already?
I think we did a very good job on the test and the quarantine part. So initially we face it's a pandemic. We never think about this situation, and they put a lot of pressure to the healthcare workers. But later, once we are ready, like Dr. Zhou already went to stay in the Wuhan, and they did a very fantastic job. So we had very good resource of that to deal with the patients. So also the very important part is the Chinese medicine part. We start to use Chinese medicine at a very, very early stage. So then we prevent the potential severe patients. So to cut off all the disease progression. That's our very good experience.
And finally, I want each of you to give me your guess, because we can probably only guess when this will wrap up and in what way. The best guess that you can come up with. Let me start with Elisabetta.
完全连不上我这里，再搞鬼。
I think wrapping up is a big question and is a tough question. I think we can potentially in the UK at least we should be asking the question: are we actually managing this? Are we responding in the right way to keep it as short as possible? And are we doing this at the level of authorities and members of the public in the right way? And our Prime Minister has said 12 weeks is going to be a crucial time. Italy as well is certainly the number of cases are going up. The Italian Prime Minister had said a week ago that because of the incubation time, the next 14 days were going to be crucial. And okay. I think it's obviously much longer than that. And we all know that the virus is going to stay with us. So efforts right now carrying on as we need to do.
Jeffrey?
Well, I could give you a number, and I think it's not unrealistic to think that we're not really going to be coming out of this until the end of 2021, to be honest. I think the larger question is, how do we adjust to it? How do we adjust in our various societies around the world to this new normal, where we're going to have to practice measures that are going to limit the transmission of the virus prior to the delivery of an effective vaccine or therapeutics, or just watching it move through populations slowly and provide the best point of care treatment possible. The main reason for doing all these control measures, one of the main reasons, is to prevent our hospital systems from being overwhelmed. We have limited bed capacity in most of the world, in all of the world. And when we have surges of infectious disease, it not only overwhelms the healthcare systems with the number of people seeking care and treatment for that disease, it also pushes aside all routine and other emergency services so that they cannot be delivered in an effective and normal way. So we need to have a bit of a sacrifice as a world and have our societies adjust to this norm where we're going to need to collectively work to keep this managed without disrupting our economies to the point where we fall into some deep depression, and that causes other forms of misery that we would like to avoid.
Some adaptations. Johan, briefly, please.
Yeah, I agree on that. I think we need to try to convince the population for the next weeks, next months, and perhaps next year and longer that these measures need to be taken, just indeed not to overwhelm the healthcare system, but at the same time try to keep the economy still going. And what I would also like to say is that I'm a bit afraid that, for example, elderly that will be isolated for a long time at home, that we should take care of them and just make sure that they don't feel too lonely. We may have psychological problems, so perhaps we should just call grandma and granddad and just check how things are going with them if we can't visit them.
And Mr. Lee?
Yeah, I think the major thing we want to is balance the development of our economy and then the stop of the virus transmission. I think that's our effort on that.
Margaret, your words?
Yes, we certainly are planning for the long haul. We would like very much to see this finish early. We can see that countries have been able to flatten their curves, drop it right down as China has done, but there is the risk of receding from other very large outbreaks. So I would not venture to put a time on it, but we are expecting to be in it for the long haul.
Okay, hope for the best. Mr. Masuzoe?
Because of the economic deterioration in the whole world, it's very, very hard for the political leaders to ask the people to continue this kind of strict control. So I'm rather pessimistic, to say, well, it's finished in a couple of weeks or a couple of months, even by the end of this year.
Okay. Professor Joe?
Hi. So as a physician, we'll try our best in the world to save lives. But I think the most important is to prevent the mild type of the patient developing into a severe or critical severe patient. So my opinion is to admit all of the mild patient or some very mild symptom patient into the hospital and to stop the development of this COVID-19 this disease, so we can decrease the numbers of the critical severe patient. That is the best way to reduce the mortality rate of the COVID-19. Thank you.
Yes, indeed. Prepare for the worst, but work for the best. Thank you very much, all the panelists. I'd like to remind you, we will have another panel discussion next week between doctors in China and from the rest of the world, talking about how should we cope with COVID-19. And thank you very much again for viewing this panel discussions. You can send your emails to CGTN Think Tank at cgtn.com. Thanks again for everybody coming to this chat room. Thank you.
Thank you.
Thank you. Bye.
Bye.
Thank you.
Thank you.
Bye.
Bye-bye.